Are you seeing any effects to the demand for your services that you think are attributable to the ACA? In other words, more or less primary care volume, more or less demand for specialty services, fluctuations in the number of visits to your emergency departments, things like that? Are you seeing anything related to volume that you could attribute to?
I don't think we're seeing anything that can be pinpointed attributable to this right now. I do think that coming back to sort of some of the changes that we're doing, we've got an initiative, Uptown and Washington Heights initiative, which is a medical home model, which is really designed to provide that continuum of care. And in that community, with that group of people, are we seeing changes? Yes, but that's because of, in part, the intervention.
Yeah.
But from a volume perspective, I think it'd be too hard to tell what's directly attributable.
I'd have to agree. I think where the change, that we're seeing change is in conversations with our insurance partners in this process.
Yeah.
New York is a little bit slow to this again, but we're seeing things in Massachusetts where insurers are linking up in ACO-like relationships with providers and are trying to change the dynamic there, and we're in those discussions. So we're seeing that emerge, but as far as patient volume effects, I don't think we've seen anything. I think we're trying to anticipate things, and I would add about some of the aspects of change is I think we all have to admit to ourselves and give ourselves permission to make mistakes. And we laugh about it and we all get uptight about it, but if you don't admit that there are going to be failures, then you will never really take any risks. And while we don't like to fail, we're going to. While I don't think this by any means will be a failure, but we've jumped into a project that I'm sure our colleagues in the audience know about, the project that we're developing a freestanding emergency department in Greenwich Village at the site of the old St. Vincent's Hospital. And that's something which we didn't know anything about in New York, on the other side of that river over here. They know a little bit about it, and the rest of the country does. No, Hudson. Yeah. On the other side of the Hudson, in Jersey, they have some freestanding EDs, but New York doesn't, except for two upstate where they were formerly hospitals and they closed the hospitals. But there are going to be changes, and I think that is an example of inpatient services morphing to provide care. And while we don't think of New York having critical access, New York City has critical access hospitals for a safety net. We do need to have parts of New York City and a metropolitan area do need that. So we are seeing that change because we've been invested in this for a while. It doesn't open up until 14, but we are invested in that change.
We'll see if it's a failure.
Some people would say you're not going to have any advancement or any improvement without failure. You have to be able to experiment and try different things.
Yeah, the trick is to be there.
Exactly, right, to survive the experiment, right? Yeah.
The trick is to have a plan B. So I think we are seeing the trend that everyone knows about, and we're seeing it quite dramatically, actually, significant increase in outpatient volume. We're actually anticipating a drop in our inpatient volume, but it's happening more rapidly than we anticipated. And all the things that have been going on for a while with the reduced length of stay and the trends that we're seeing everywhere are really coming to fruition for us. So it's validating actually our plan that we're implementing, and we think it's going to go more and more in that direction.